Okay, good morning, everyone. This is Jenny Maurer here, the Project Launch State Coordinator. Thank you for joining us for the Wisconsin Child Psychiatry Access Line for Primary Care Clinicians discussion. Before I get into kind of the meat of our presentation, can folks type into the question box and let me know that the audio is okay? Can everybody hear me? I'll take a second to wait for some responses. Okay, so got one person who says they can hear me. Okay, great. Sounds good. Well, wonderful. Thank you so much for joining us on rather short notice. Today I'll be presenting with Dr. Ariana Kyle from the Wisconsin Medical Home Initiative, Dr. Rick Imler, a child and adolescent psychologist here in Wisconsin, and Kia Labraki, the executive director of the Wisconsin American Academy of Pediatrics. And so thank you to everyone for joining us here today. And I'm just going to make Rick a panelist. And Rick, now you should be unmuted. Rick, are you with us? We'll see. We'll get started, but Rick, I think you're unmuted. So our agenda here today, we wanted to walk all of you through kind of our idea here to create a mental health consultation line with child psychiatrists for primary care clinicians. So we're going to walk through some key points related to this idea, and then we want to open it up for the group to ask questions. So again, our goal here is really about how do we extend critically needed services, behavioral health services, to primary care clinicians. We know that primary care clinicians are being asked to support the behavioral health needs of kids in their care, but they don't always have quick resources at their disposal to support those needs. And so creating a mental health consultation line staffed by child psychiatrists would be a great way to help support primary care clinicians in meeting the needs of those kids. So to put this concept and this idea into a little bit of context, and I'm probably speaking to folks who know these details even better than I do, but we know that lots of kids have behavioral health challenges, and so almost 20% of children in the United States suffer from some form of mental illness, and only a small number of those kids are actually receiving treatment. And a really compelling statistic to me is that kids in preschool face expulsion rates that are 3 times higher than kids in grades K through 12. And this is in large part due to lack of attention to social emotional needs. So child care providers are not able to address behavioral health issues, and they're asking parents to leave. And so we all know that Wisconsin's children really need to be healthy physically and mentally, and that both components are really critical to the future prosperity of our state. But even though we all know that, we still face a lot of challenges in supporting the mental health of kids in our state. So here are just a few key statistics about children's mental health in Wisconsin. So in 2009, most counties had fewer than 4 child and adolescent psychiatrists, and most had none. And another really compelling statistic is that between 2003 and 2006, there was a nearly 50% increase in the use of antipsychotic medications for children 17 years of age and younger. And so before I continue to talk about that, I wanted to bring in a couple of different perspectives. And I'm wondering, Ariana, are you unmuted?
I am now.
Could you just tell us a little bit about yourself and some of the lessons you've learned as you've been working with primary care clinicians?
Sure. So as Jenny mentioned, my name is Ariana Kyle. I am an employee of Children's Hospital of Wisconsin, and I coordinate several publicly funded grants that really work to provide support to primary care clinicians in providing pediatric medical home related services. So we focus on a few areas in which we support primary care clinicians across the state. The first is the early identification of kids with developmental delays, primarily through the routine use of validated developmental screening tools within well child care. And then the second area where we offer support to primary care clinicians is around behavioral health integration into pediatric primary care. So we've had the good fortune of doing this work for a number of years now, working very closely with Project Launch, which Wisconsin is fortunate to have 2 Project Launch sites, one in Central City, Milwaukee, and the other up in Red Cliff. So the Project Launch team really charged our state with really looking more closely at how can we support pediatricians and family physicians and pediatric nurse practitioners and physician assistants in behavioral health integration, which is obviously a huge topic. And we started out by holding a series of stakeholder listening sessions in Central City, Milwaukee, where we had really wonderful input from a variety of groups. We had family physicians and pediatricians and child and adolescent psychiatrists, and we had parents, we had therapists, we had hospital administrators, we had payers. Anyhow, everyone was in very strong agreement that primary care clinicians are providing the majority of mental health services for kids across our state, particularly in the northern half of our state, but also very consistently and across several different studies, the majority of primary care clinicians are saying we didn't receive enough training in medical school or in residency to really feel confident in providing some of this care. And so our work in this area really started out by supporting primary care clinicians around routine pediatric mental health school use. And it continues on, but I would like to say that in Wisconsin, the data that we've gathered really reflects the national data on this topic, which is primary care clinicians are doing the majority of mental health provision for kids. However, the majority of them say we could really use additional support in this area. So that really was one of the key underpinnings to really promoting the development of the access line. And I would like to say I was really happy to see that there were so many pediatricians and family physicians registered for today's call, and I want to be very careful to acknowledge that this idea is not a new idea for our state. There are people either on the call today or who couldn't make it, who have really been actively promoting this idea for a number of years. Dr. Rick Imler, a child and adolescent psychiatrist, is one of those, and he will speak later on today. So I want to say, you know, this proposal paper and the access line is really, really reflects a number of years of work and dedication to this area.
Well, thanks, Ariane. I think Rick is having some audio difficulties. Rick, I think if you disconnect and call in, we might be able to get your audio. But in the meantime, while Rick figures that out, and thanks, Ariana, for sharing that perspective. So again, we know that primary care clinicians are really being called on to provide behavioral health support for kids in Wisconsin. And this idea is really about looking at how we can support that need. And while we wait for Rick to try to get his audio figured out, I want to go back to a couple of key statistics about antipsychotic prescribing here in Wisconsin. And Rick hopefully will get on the call and can speak more eloquently to this. But I provided a couple of key data points that I think are really compelling. One is that 3% of children on Medicaid had an antipsychotic prescription, and 27% of children in foster care received an antipsychotic prescription. So children in foster care were almost 9 times as likely to also receive multiple antipsychotics at the same time as children who are not in foster care. So I think what we're seeing here is that it's telling a story where kids are having a lot of different behavioral health issues. Folks in their care team are trying to support them, but I think that there are other strategies that we can use to support those needs. And so the idea here that we're discussing, again, just to remind us, is how can we provide that critically needed support to primary care clinicians? And creating a mental health consultation phone line with child psychiatrists is one way that we can help support the needs of behavioral health for children. So our team did a little bit of research looking at what are different key components that programs throughout the country have used. And so we'll just walk through a few of these here. So one is access. So in many states, they have a telephone hotline that primary care clinicians can call during typical business hours. And consultation is typically in a rapid response format where they get a response within 24 hours. Most call lines have a number of different staff that are supporting the call line, and the team typically consists of a child and adolescent psychiatrist, child psychologist, social workers, and other support staff. And a really key component that successful call lines have is that they have infrastructure. They have administrative support to do the administration work, to monitor the program, to do evaluation, to make the line run smoothly. Some additional components that most programs have is that beyond providing mental health consultation with the child and adolescent psychologists, a lot of work that the call lines do is assist primary care clinicians with referrals to community resources. And so they're really working to build those connections to resources that are in the clinician's community. Another key component of a call line is collaboration. So as you can imagine, to connect clinicians to resources in the community, it really requires an extensive network of collaboration between different healthcare organizations and community organizations that are all working to support the needs of kids and families. And finally, another key component is that many of the programs do have the option oh no. Are folks still there?
I'm here.
Okay. Something happened, but can you still see the...
Yep. It's there.
Okay. All right. I think my network just went somewhere for a second, but that's okay. I think we're okay. All right. So finally, I was saying that primary care clinicians can be reimbursed for their time spent accessing the consultation services. So programs also take a couple of different approaches in a couple of key areas. Many states have voluntary access to the call line where a primary care clinician can call the line for support as they feel it's needed. Some states do have a mandatory component when they're seeking a second opinion for medication prescriptions. Another component that some states have adopted, particularly Minnesota, is to offer technical assistance and training to primary care clinicians. So Minnesota has, I think, a 2-day institute that they run maybe every or twice a year. So trying to provide more in-depth training to support primary care clinicians. So Massachusetts, and Ariana can correct me if I'm wrong here, I believe was the first state to really develop this idea on a statewide basis. So the Massachusetts Child Psychiatry Access Project has been in operation since July of 2005. And their program serves virtually all primary care practices in the state. And 70% of clinicians access the service each quarter, so really a phenomenal amount of activity in Massachusetts. So in 2012, they just shared some of this data. The service supported 9,600 patients through almost 19,000 activities. So really seeing a lot of, supporting a lot of families and primary care clinicians. And the Massachusetts program also did a survey of their primary care clinicians, and 90% of those surveyed reported that they agree or strongly agree that the consultation was useful. So providers in that state, or clinicians in that state, really value the service. So financing, everybody wants to know about how the states pay for it. So each program uses a variety of different funding structures to support their efforts. Massachusetts relies on collaboration between a number of different university hospital systems, and they received $3 million per year in state general purpose revenue to fund their program. And so to put it in perspective, based on the population of children in that state, that's $2.11 per child in Massachusetts to fund the program. Minnesota, which has just in the last few years started to put their program together, received $1 million per year that includes costs for administration and evaluation. I'm going to try to Rick, it looks like you're muted on your end, so hopefully we can get Rick's perspective.
I'm here now.
Oh, hi, Rick. Great.
Can you hear me?
We can hear you. Thank you. So, Rick, sorry for the audio troubles. I'm glad you're able to join us now. I'm wondering if you can provide a little bit of your perspective on the perspective of the child and adolescent psychiatrists and through the interviews that you've done in Wisconsin.
Okay. And maybe by way of some background, I've been providing services up in a 6-county region in northern Wisconsin since 1998, and during quite a bit of that time had the privilege of working with many wonderful primary care providers and just discovered what amazing things they're doing, and that sometimes with relatively limited support, how much they can feel comfortable doing, though since they're not trained child psychiatrists, it's a challenge. So that experience dovetailed into some work I did with the Department of Health Services, the Bureau of Treatment, Prevention, and Recovery last year, looking at some best practices for prescribing. There was about 20 primary care interviews, 20 with mental health specialists, some contact with advocates, and 7 counties. And uniformly, a huge concern was access to child psychiatry, as was mentioned earlier, but also the importance of, when available, child psychiatry access. For instance, Dr. Gabriella Hangiandreo in central Wisconsin is providing a wonderful resource to primary care clinicians with ministries. So, and that led to some of the contacts that you mentioned with particularly Minnesota. So my personal experience and the experience of others, as well as the need, all seemed to come together last year.
Great. Thanks, Rick. So that kind of brings us to the end of our more formal presentation, and I guess to conclude, as Ariana mentioned, this is not a new idea. It's an idea that's been championed by a number of different groups and individuals, and it's an exciting idea for Wisconsin. And so we're really excited about this concept and think it would be a great way to support clinicians here in our state. So now I'd like to field any questions. I'm debating whether or not I unmute everybody. There are 23 of you. Hopefully that will work. I'm going to unmute everybody, and we'll see how this goes. Let's see. And now I have to figure out how to make this unmute. Oh. Okay. Are there any questions? I have to unmute you all individually. Any questions?
So this is Dr. Lanehart.
Yes, go ahead. Thank you.
So the question I have is, so I think, I just want to say that this is wonderful. It's, just tremendously needed. And in regard to, Minnesota and particularly Massachusetts, do we know the number of child psychiatrists, per capita of children in the state? Because it seems like a critical piece of this, extremely important project is having enough child psychiatry support to be able to provide, adequate consultations to the pediatrician. And I'm a child psychiatrist and a pediatrician, so I just really want to, compliment what all of you are moving forward.
So I think that that's a good question. Let's see. Sorry, there's a lot of background noise. Yeah, there's lots of feedback. Okay, I think I'm going to change strategies here. I'm going to mute everybody, and you are able to raise your hand. And so let's try to answer that question. And then I can respond to, we can have individual people be unmuted. So I don't know off the top of my head how many child and adolescent psychiatrists Minnesota or Massachusetts have, but I think what's exciting about this idea is how do we maximize the resources that we do have in the state to provide that support across the state, particularly in communities where there are few to none child and adolescent psychiatrists and other, critical mental health staff. I'm wondering, Ariana or Rick, do you have other thoughts on or responses to that question?
I have a little.
Go ahead.
Can you hear me?
Yes, thank you.
Okay. Well, one of the approach that was used in Minnesota is the $1 million contract is actually dispersed among 3 major organizations, including Mayo. And so from within the organizations, they provide the child psychiatry resource. However, it should be mentioned that this is in many ways a shared consultation model, although child psychiatry is listed as a central resource. There's support and triage from other mental health professionals, at least in the Minnesota model and in the Massachusetts model. Within the state, there are wonderful islands of resources. For instance, Rogers has several, and I'm, just kind of throwing out possibilities here, but Rogers has several. The Children's Hospital of Wisconsin, with the medical college, the university, and interestingly, even in the state system, there are child psychiatrists doing primarily adult. That are, I know some of them personally, are wonderful child psychiatrists. So my sense is there may be some opportunity even bringing folks back into the labor pool, if you will, who might not be doing as much child.
Great, thank you. And before we go to the next questions, I skipped over a couple of critical pieces. Kia, I'm wondering if you can give us an update on the chapter's outreach and next steps with this proposal.
Sure, I'd be happy to. Can you hear me, Jenny?
Yep.
Okay.
Yes, we can. Thank you.
Okay, sure. I'm Kia Labraki. I'm with the Wisconsin chapter of the American Academy of Pediatrics and the WIAAP Foundation. And our chapter has had this issue on its radar for many, many years. We have tried to address it in a few ways, one through a mental health webinar series for primary care clinicians, where we actually pair child and adolescent psychiatrists with our lead pediatricians who do case studies and didactic presentations together and make themselves available for questions and answers at the end of those hours. It's once a month. And we've talked for a long time about what other ways we might help in this arena. So when this opportunity came up and when the announcement was made about the new budget appropriation for mental health services, all of us sort of coalesced together with the proposal that all of you have seen. And I'm happy to say that nationwide in the Academy, there are a lot of models of this type of system not only being implemented, but actually working very, very well, having great results, being funded, and so we have a lot to draw upon. This isn't a, a new, no one's ever done it kind of project, so I feel really confident about our ability to gather that kind of feedback and information to make this a workable model. The chapter has put together a request to we put together a request to be invited to a hearing this week in NENA for the Assembly Task Force on Mental Health. They are doing listening sessions and hearings about this and other issues relative to mental health. So we are intending to present briefly our support on this issue. Some of you who registered for this call saw that on our website there is an article linking to that letter, the proposal, and some other talking points and things that might be of use. We are able to submit on our members' behalves if they are not able to come and testify personally but would like to register some written commentary. We are able to submit those at that time, and so I can gather those electronically, and you have my email address there, but also if you look at wiaap.org, all my information is there as well. And I think that's it for now. Jenny?
Oh, I was talking but had muted myself. So I'm going to unmute Tracy, and then I'll try to go in order of folks who've raised their hand. So Tracy, are you there? Tracy? Let's see. It sounds like Tracy's maybe still not able to access the audio. So let's try Charlene had a question. Charlene, are you there?
Yeah, hi. I go by Charlie, actually.
Oh, I'm sorry, Charlie.
I signed in by Charlene because that's my different name. I was wondering, what is a realistic budget that you would require to be able to do the evaluation that Minnesota and Massachusetts are doing? So for our state, do you guys have a budget? And I'm sorry if I haven't checked the web page.
So that's a good question. I think we have not, to be honest, explored it with that much depth. I think we would love to be able to do an evaluation, and from my research and exploration about other states, I think that the evaluation has typically focused more on clinician satisfaction, and I think there is an opportunity to take a more in-depth look about outcomes. And Ariana and Rick can chime in here on this as well, but I don't think that there's been a more in-depth evaluation, if I'm remembering correctly. Rick or Ariana, other thoughts on that question?
No, there hasn't. It's a great question, but I'm not aware of anything in more depth than we're offering.
Well, certainly with the current, like the move towards ACOs, that if we could show that it's much more cost effective to be able to do this, certainly that would be a great outcome to measure.
Yeah, I mean, I think there's a lot of potential for some really great data, but it hasn't been done yet. Included in the paper that that we've also circulated, we did include some cost-benefit data from the state of Washington that wasn't explicitly related to a call line, but was related to second opinions for prescribing of ADHD medication, and they did show significant cost savings by having a second opinion. So it's not exactly the same thing, but is related. So let's, Charlie, I'm going to mute you, and I'm going to go to the next question. Let's see, Becky, I'm trying to unmute you. It looks like you're muted on your end. And Tracy, you're still unmuted.
Can you hear me okay now?
Oh, is that Tracy or Becky?
Oh, this is Becky.
Oh, hi, Becky. Go ahead with your question, please.
Okay. This is Becky. I'm calling from Marshall Clinic. My first question, I think Kia has addressed. I was wondering what kind of support we have in our state for such a program. I think it is a very good idea. The second question I have is, as we prepare for patient-centered medical home meaningful use and ACO clinical quality measures, one particular measure that we are planning for is depression screening. And I know that one of the concerns that have been brought forth by providers is in relation to the resources that are available to patients that are identified with depression based on this screening. So realizing that this service would be a resource for providers, is there also some discussion about expanding services available to the patient and family, specifically around counseling potentially?
Rick, maybe is that a question you could speak to?
I could try to.
Great, thanks.
And I'm drawing a bit on the experience of Massachusetts. And Jenny, did folks get that great paper on the Massachusetts model, a 20-page, if they're really interested in depth?
I don't believe that they have, but we can look to posting some key resources, potentially on AAP's, Wisconsin AAP's website, if that works. Okay. For Kia.
Sure, that'd be fine. That'd be great.
Okay. Well, I'm mentioning it because part of the function is the triage and referral, the linkage. And my experience with many primary care providers is, who do we refer to that's providing evidence-based therapy? And that in Massachusetts they keep extensive resource lists. So when folks call in, that's available, and they keep those updated. So that's one way that could be addressed.
Great, thanks, Rick. And Dr. O'Grady, I'm going to unmute you, and I'm going to remute Becky. Dr. O'Grady, did you have a question? Dr. O'Grady, I have you unmuted. It says you're unmuted on my end. Let's see. Technology is always an adventure. Okay, well, we'll try to come back to Dr. O'Grady for his question. And I do see, Ariana, that you're trying to share some of your perspective, and I'm not sure why it's not letting you. Let's see. Let's go to some additional questions. Okay. Scanning through the... Tracy, we're still trying to get you. It says that you're unmuted. Okay. So someone typed a written question about whether or not this was something that was for sure going to happen in Wisconsin, and if so, when. And unfortunately, this idea is still an idea that's in development, and we're really trying to share this exciting possibility, but it's just an idea that's in development here in Wisconsin. Are there other questions?
Maybe, Jenny, if there are folks you're having trouble muting, you could just encourage them to type it in.
Yep, that's a great idea. So if folks are not able to be heard over audio and would like to type in a question, you can do that on the question box on the right. And Ariana, I'm going to try to dismiss you, and you can sign in again. And we'll see. So I'll give folks a couple of seconds to type in additional questions. And Ariane, I'm trying to fix yours. Okay, so I don't see any additional questions yet. Dr. O'Grady or Tracy, would you like to type your questions in? Okay, let's see, I think.
This is Kia. I would
Yep.
just say a couple other things while we're waiting, if we're able to get those comments. If there are people who are on the line who are not necessarily chapter members, any comments that you may have in support can still be funneled through me. I would be more than happy to carry those on your behalf on Wednesday. And again, if you just want to email them to me, I would be more than happy to do that. And whether or not you're a chapter member, if anyone were to have any more questions, comments, suggestions as far as the link to the clinician piece of this, the pediatric or other primary care provider link to this, I would encourage you to give me a call, and also to spread the word to your colleagues, to do the same, to either provide the testimony or to contact me. We are keeping lists. We are keeping a master list of all the different people who sort of have an invested interest in this, so that you will always get, you know, be it that we are doing an update or a survey, or have information to share on this topic. And certainly we're all very invested in it, so I really encourage you to stay in contact with us.
And Ariana, did we solve your microphone issues? Are you there? Not yet. Well, so there are a couple of questions from Mark Morrison. He asked about implementation of statewide telehealth consultation network. I'm wondering, Rick, if you could speak to that.
Can you hear me?
Yes, we can.
Okay. The model has been available on an individual basis. I believe that Dr. Randy Cullen has worked with several counties, and Dr. Genesel Kuntz is also on an individual contract basis. Children's Hospital, I believe, has also provided a resource to the Fox Valley with telemedicine, and I believe at one point also to Lincoln Hills Correctional Facility. In terms of anything planned on a statewide basis, I'm unaware of anything that would be supported by the state. One of the challenges that we have is that a great deal of the public mental health services are organized and partially funded by the counties. It's certainly a great idea. There's a great need, but I'm not aware of any formal initiatives.
This is Kia. I can address that on a very brief and not, you know, super helpful level, but I did have a phone meeting with the Department of Health Services earlier this year, because we have been advocating for reimbursement of teleaudiology services, which is a different animal than this, but it does fall within the realm of doing logical and better and earlier interventions with great resources and means, and making sure that people are getting paid for it, and in that case they are not. So sort of making that case. And as a result of getting in talks with the Medicaid folks about that, they also asked us to participate in a little bit of brain teasing about telehealth in general. They are doing sort of an environmental scan of telehealth in terms of cost savings and trends, and what are other states doing, what systems exist in our state. And through the course of that conversation, I mentioned, you know, about 8,000 times the need to incorporate mental health services in whatever model they decide to pursue. So it is on their radar, but I think it's mostly in the exploratory mode right now.
Hi, all. This is Ariana. Can you hear me now?
Yes, we can. Thank you, Ariana.
I'm so happy. Sorry about that. I'm not sure what happened. This has been really good conversation. And I have a few just comments that I'd love to make, just hearing some of the discussion that has happened, so it's not a direct connect to the topic Kia was just talking on. But I want to make sure that folks who are on the call understand the breadth of support that we've seen supporting this idea. That not only has the Wisconsin chapter of AAP endorsed the access line position paper, but also the Wisconsin Academy of Family Physicians, as well as the Wisconsin Council of Child and Adolescent Psychiatry. And so I think that really widespread endorsement of this idea really speaks to the acknowledgement of the need, as well as the potential impact of this access line. May I make one additional comment? There was a question earlier on the budget that we were proposed, or that would be proposed for Wisconsin. And so you saw the figures that Jenny discussed about Massachusetts spending annually around $3 million, and Minnesota around $1 million. And you know, I think the Massachusetts Child Psychiatry Access Project, or MCPAP, is really the gold standard in this area. You know, they have 6 regionally based teams. I heard Rick mention that they're staffed by not only child and adolescent psychiatrists, but also a therapist and a care coordinator. And as they've kept data over the last almost 8 years, they found that, you know, about 50% of the calls from primary care clinicians really are channeled directly to the child and adolescent psychiatrist. But the remaining about 50% actually are managed by the therapist or the care coordinator. So I think it really speaks to the breadth of support that's really needed in this area, that it's definitely that clinician-to-clinician support that's part of it, but it's broader than that. And so I think the regional model that Massachusetts uses is more expensive, for sure, but I think those regional teams are really able to offer region-specific resource information. Not to say that the more centralized programs like is done in Minnesota isn't valuable or worthwhile, but just trying to give some insight as to why the Massachusetts program might be more expensive.
Great, thanks, Ariana. I'm glad we were able to get your audio working. I appreciate your persistence. So unfortunately, we haven't gotten Tracy Order's audio to work, so I wanted to relay the question that she typed. So she asked, which partners across the state are we looking to engage, and are we looking at a single entity as a preference or multiple providers? So I think our hope is that as we start to share this idea out with the community, that interested partners and champions will start to come forward. And I think the collaborative model, as Ariana just pointed to, has been really successful in Massachusetts. But I think that we haven't certainly made any decisions. This is an idea that in Wisconsin, at least from our perspective, is really still an idea in development. Any of the other presenters have additional things to add to that question? Ariana?
I think that puts it very well.
Okay, great. Well, so last call for questions. I haven't seen any in the last. Let me just. Oh, here's Dr. O'Grady's. I'm just looking through the questions box that folks typed in. Let's see. So Dr. O'Grady said there are over 125 child psychiatrists in Wisconsin now that are part of the WCCAP. Let's see. So I think that we've covered most of the questions that folks had typed into the box. Any other concluding thoughts from any of the other presenters?
This is Kia. I just want to thank everyone for calling in and being interested in this, and certainly to Ariana and Rick and Jenny for the wealth of work that went into putting this together and really getting it together in a short period of time for the presentation to the task force on Wednesday.
Great, thank you, and I'll echo Kia's thanks. I know everybody has a busy schedule, and I really appreciate everyone finding time on such short notice to join us. We'll look to post an archive of this webinar as well as additional resources on the chapter's website so that you can share this information with your colleagues and they can contact us with any questions. So thank you very much, and we'll be keeping you posted on the next steps with this initiative. Have a great afternoon.